Imagine that, before deciding between direct pulp capping, pulpotomy, and root canal treatment, we no longer have to rely primarily on the patient's description of pain, cold testing, and our clinical impression, but can instead measure a biological signal indicating whether the pulp still retains a genuine capacity for recovery. It sounds somewhat unrealistic, doesn't it? Yet this is precisely the concept explored in a highly interesting doctoral dissertation from the Harvard School of Dental Medicine published in 2026, Development of a Novel Murine Model for Reversible Pulpitis and Identification of Biomarkers, Exploring a Neurodegenerative Hypothesis, by Nicolas Ouellet. The problem addressed by the authors is one we know well from everyday clinical practice. Our current diagnostic tests are reasonably effective at distinguishing vital from necrotic pulp, but they are far less reliable when confronted with a much more important question: is the inflammatory process still reversible, or has the pulp crossed a biological threshold beyond which meaningful recovery is no longer realistic? An additional challenge is that pain is not a dependable indicator of the true histological status of the pulp. The thesis notes that a substantial proportion of patients with irreversible pulpitis may experience no pain at all. This issue has become particularly important in the era of vital pulp therapy, where the objective is to preserve tissue that, in the past, we may have removed far more readily. The researchers therefore proposed a particularly compelling hypothesis. Perhaps pulpitis should not be viewed solely as an inflammatory process, but also, at least in part, as a process of neuronal injury. The dental pulp is exceptionally richly innervated, and degeneration of its nerve fibers may therefore leave behind a molecular signature that could potentially be measured. To investigate this concept, the researchers developed an experimental murine model in which the pulp was mechanically exposed and left in contact with the oral environment for different periods of time, after which it was directly capped with biodentine and allowed to heal for 14 days. Histological analysis revealed a striking difference between immediate treatment and a delay of only 24 hours. When the pulp was capped immediately after exposure, approximately 35% of the pulpal space showed necrotic or inflammatory changes. After 24 hours of open exposure, that proportion increased to approximately 85%. Even more interestingly, the immediately treated pulp retained a substantial proportion of its neuronal architecture, whereas after 24 hours there was an almost complete loss of beta-tubulin type 3 signal, a marker used to assess the integrity of neuronal axons. In other words, in this model, the transition from reversible to irreversible disease did not merely resemble more severe inflammation. It appeared to involve profound structural degeneration of the pulpal nerve network. Another finding is particularly intriguing. The bacterial burden did not simply parallel the extent of necrosis. After 24 hours, bacterial colonization remained predominantly concentrated within the coronal portion of the pulp, while approximately 85% of the pulpal tissue already demonstrated necrotic changes. This supports the concept that tissue destruction is not determined exclusively by the direct penetration of bacteria, but also by the host response, including immune cell influx, increased intrapulpal pressure, impaired microcirculation, and the resulting cellular death. Perhaps the most compelling part of the dissertation begins when the researchers attempt to identify a molecular signature of these pathological changes. Instead of focusing on conventional inflammatory biomarkers, which may also be elevated in numerous unrelated diseases, they analyze proteins associated with neuronal injury and neurodegeneration. Using a highly sensitive proteomic platform, they examine gingival crevicular fluid, saliva, and pulpal tissue. Several particularly interesting candidate biomarkers emerged. Nerve growth factor, or NGF, was significantly increased in pulpal tissue in the reversible pulpitis model. This is biologically plausible because NGF is associated with neuronal responses to injury, nociception, and enhanced pain sensitivity, meaning that it could potentially represent a marker of a pulp that is injured but still biologically active and capable of mounting a reparative response. In irreversible injury, however, a different biological pattern emerged. Neurofilament light chain, or NfL, showed a significant increase in gingival crevicular fluid. This protein is particularly interesting because it is released during axonal injury and is already being investigated as a biomarker of neuronal damage in other areas of medicine. At the same time, certain neuronal proteins, including SYE1 and SCG2, decreased, which is biologically coherent if nerve terminals and neuronal function progressively disappear as pulpal degeneration advances. Another promising candidate was glutaredoxin, or GLRX, a protein associated with the response to oxidative stress and the recruitment of phagocytic cells. Its increase from reversible to irreversible pulpitis raises the possibility that future testing might provide not merely a binary answer of healthy or diseased pulp, but rather a molecular indicator of disease progression. If these findings are eventually validated in humans, the clinical implications could be substantial. Instead of attempting to infer the histological condition of the pulp from symptoms alone, we might be able to collect a small sample of gingival crevicular fluid or another oral biological sample and obtain a more objective assessment of neuronal injury. The clinical question might then evolve from, does the tooth respond to cold? To, do the biomarkers indicate that the pulp still retains a biological capacity for recovery? Nevertheless, this study does not yet demonstrate that such a diagnostic test can be introduced into routine clinical practice. The sample size was small, the research was performed in mice, and murine anatomy, microbiota, and immune responses are not identical to those of humans. In addition, several biomarkers did not demonstrate consistent statistical significance, and the proteomic analysis was restricted to a predefined panel of proteins. For that reason, I would regard this study as a highly interesting proof of concept rather than as a basis for changing current clinical protocols. Its greatest value may not be that it has identified a definitive biomarker, but that it challenges the way we conceptualize pulpitis. The boundary between reversible and irreversible injury may not simply represent a threshold of pain intensity or inflammatory severity. It may instead represent the point at which the pulpal neuronal network begins to undergo irreversible degeneration. If, one day, we are able to measure that transition reliably in a patient, the decision between preserving vital pulp tissue and removing it could become far less subjective than it is today.